Amit, Manishma, how are you? Wait, I can't hear you. No, I still can't. Let me see. I think my sound is on and your microphone's on.
Microphone. Now we can hear me?
Yes, I can.
Yes, great.
Hello, Aleichem. How are you?
Fine. So you know a little bit Hebrew or
Uh,
not at all?
Only enough to say hello.
Nice, nice.
My my trip last November inspired me to start learning to read again. Uh, I read like a first grader, basically.
Yeah, but it's good that you're trying.
At least, yeah, I'll learn hopefully in my days.
It's not that hard.
No, it's
No,
got to be easier than English. Uh,
uh, no, no. We used to study English at school, so it's easy, but no, no. I'm trying to study Spanish
oh,
with an app,
uh,
so trying to.
uh-huh.
So it's pretty easy, not that hard.
It's hard to use it if you don't, or to learn it if you don't use it all the time.
Yes, if you're not speaking with anyone.
And
So
why Spanish?
because my parents used to talk to each other.
Oh, you
So
come from
I caught
Spanish
some,
background.
words, and I know some when people speak, I understand what they're saying, but
Yeah.
I don't know how to speak. So why not?
Your parents came to Israel from where?
My mother from Turkey and my father from Bulgaria. So
Where does Spanish come in?
because when you speak to each other in Ladino, it's a
Uh,
Spanish, so they know how to speak Spanish.
Interesting.
Yes.
So how do we look for this morning?
Here in Israel, it's evening almost.
Hmm.
It's 5, and I doctors usually work at this time. It's their working hours because children they finish school or kindergarten at 4:30
Yeah,
or something. So only then they are coming,
yeah,
to the doctors. So
sure.
not all of them can join us, but we are happy that each one that is joining us, it's a blessing.
Good, good.
Yes.
And you recorded the session. Did people get to see it, the first session?
Yes, yes, I sent to the one who asked me. I sent it
Yeah.
for them, and I also add it to our website so anyone can see it if they
Oh,
want. It's on our website. So
all right,
yes,
all
so
right.
we
So
have 2 minutes.
I'll do a very brief summary of the first session,
Okay,
and then I'll go into some more detail. I'm going to talk about how I use MyoBrace in my practice.
okay. This is
Right.
important for them to know.
Yeah. And and I know we have one more session. I had an email with Musha about November
Okay.
this morning. We're going to talk, I guess, after Pesach
Mm-hmm.
and see what we can do about getting some live workshops going for November.
Okay. We are working on it. I told you that
Yeah, yeah.
yes.
All
Okay.
right. It's 9:59. Do you want me to
Yes, let's start. And you
let
want
me
me to speak in Hebrew just a second?
yeah,
I
sure.
will
But
speak in
do it
Hebrew.
before you start. Let
Mm-hmm.
me just make sure you're seeing the right things. Can you see
Okay.
the presentation title?
No, I can
Or,
see you and clinic.
oh, then I have to share, right?
Yes.
Let me just, let me do that.
You want me to? You are. Oh,
Yeah, I do. I want to make
Great.
sure you're
Now,
seeing the
yes.
right screen.
Yes, now I can see the right
And,
screen.
and you
Great.
see just the slide. You don't see my
Yes,
press.
yellow slide.
Okay. All
Yes.
right. Very good.
Okay, so I'll speak in Hebrew for 2 minutes, and then you can start.
Mhm.
אז ברוכים הבאים לוובינר מקצועי זה. אנחנו שמחים לארח את דוקטור בארי רפאל, מומחה בתחום רפואת השיניים. במהלך המפגש דוקטור רפאל יחלוק איתכם ידע מעמיק, עדכונים טכנולוגיים ופרקטיקות חדשניות שיכולו לשדרג את איכות הטיפול במרפאה שלכם. הוא יראה לכם בעצם, יסביר איך הוא מטפל במיוברייס במרפאה שלו. כמובן, כל מי שמשתתף, אנחנו מציעים לכם את כל העזרה שאתם צריכים מבחינת חומרים שיווקיים, קורסים אונליין, יש לנו אתר מידע, תרגילים בעברית עם סרטונים יעלו בקרוב, יש לנו תחנות אונליין לרכישת המוצרים, כל מוצר מגיע עם חוברת תרגילים למטופל, ויש לנו קטלוגים נוספים, וכל שאלה או עזרה אם אתם צריכים, אז אני תמיד זמינה עבורכם. וזהו, יש לנו הטבה מיוחדת של 1+1, אתם נכנסים לאתר, רוכשים מוצר אחד, בהערות רושמים את המוצר השני שאתם מעוניינים בו, ואנחנו יוצרים איתכם קשר למחרת, ותקבלו את המוצר. אני רוצה שיהיה לנו וובינר מעשיר, מועיל, ואני מזמינה אתכם לשאול שאלות בסוף המפגש, ותודה רבה, ודוקטור בארי יתחיל. We will start now. Thank you.
תודה.
תודה.
So good evening, everybody, and welcome. And hello to those who are going to watch the recording. This is the second of 3 webinars that I'm giving about MYOBRACE and the way I use it in practice. We're going to be talking about some practical approaches today. It really is just a smattering of all the ways that I use the MYOBRACE. There are a lot of details that I can't go into in this short period of time, but I want to give you an overview of how this seemingly very simple system can be used throughout a pediatric and an orthodontic practice. So I'm going to be just doing a slight review of what we did last time and look at the range of services. I'm going to talk about how I use the MYOBRACE in practice, some of the components of the MYOBRACE system. I'm going to give you just a little introduction on training your staff, because having the staff run the program is really essential for this program to work in a dental practice. We'll talk about some adjunctive therapies. So this is the airway dentistry timeline, and it's a busy slide, but I'm just going to look at this area on the right to give you an overview. You know, we started getting involved in this when we talked about obstructive sleep apnea, for which there are only some limited treatments, including CPAP, mandibular advancement devices, some surgeries, and so forth. But we now understand that obstructive sleep apnea is just the end stage of a long lead up of problems that really starts from birth. They include problems with breathing while you're sleeping. And we call that breathing disordered sleep, not sleep disordered breathing. It's not really a problem of sleep, it's a problem of breathing. Why? Because the upper airway is not formed well enough to allow air to pass through it easily, and flow is limited. Why is that happening? Because our faces are not filling out quite the way they used to just some few hundred years ago, that our bones are not developing fully. Why does that happen? because the way we use our mouths, the way we breathe, the way we chew, the way we swallow, and especially the way we posture our tongue to breathe during rest and breathing has changed. These are soft tissue dysfunctions, which are the cause of craniofacial deficiency. But why is this happening to us? And that is because we have to adopt certain behaviors or compensations, or in dentistry we call them parafunctions, because of the change in the modern environment and the stresses that it causes us. That's a very brief overview. From an anatomical point of view, this is the change we're seeing in the human face when our soft tissue function changes, when breathing changes from nasal breathing to open mouth breathing, when the tongue is low in the face, and in the mouth, the face changes in several important ways. And it's mostly the maxilla, and that the maxilla, of course, is from the lower border of the orbit all the way down to the teeth. It's not just the palate, but the maxilla is no longer growing upward and forward in the face, but sinking down and back. That not only is it the amount of space for the teeth that's lacking, but the shape and size of the nose is changing as well as the internal portion of the nose. And then finally, the lower jaw is having a little difficulty developing as fully as it wants to because it's limited by this small maxilla. This change in paradigm is called craniofacial deficiency. You may have heard it called craniofacial dystrophy by Mike and John Mew, but it is a universal change in the way the human face is growing, and this is true all across the planet. Really, there's no difference whether they're different genetic or racial background. The result of this is a combination of disorders that dentistry has been trying to deal with for many decades, and often unsuccessfully. But many of these disorders are related to this craniofacial deficiency. I'm not going to go into the details here, but when you start to see the common etiology of all these things, they really start to make sense in a way that we've in dentistry have struggled with for many years. So that's the change in modern man. So let's talk a little bit about how I use MYOBRACE in my practice to help deal with these craniofacial deficiency cases and their sequelae. So let's start off with the discovery program. This is a way of helping me understand what's going on in the modern malocclusion and craniofacial deficiency. There are three domains that I have to deal with. To put it simply, we call it structure, function, and behavior. Structure being the anatomy largely of the skull, the jaw size, and then of course the spaces through which we breathe from the tip of the nose down to the bottom of the throat. The function is the physiology of our system, which is being overburdened by things like inflammation and swelling and mucus and infection and so forth in the modern era. But the third is behavior, and the behavior are habits that we've had to adopt in the face of these modern stressors. And the underpinnings of these problems really are because of things that we do. That's either as a society or as individuals. And so we have to look at things like breathing and swallowing and sleep, nutrition, and posture. So um, my treatment continuum includes all the kinds of things that we can do to help a child grow properly or help an adult recover from craniofacial deficiency. Not to go into too much detail on this slide, but these treatments range from taking advantage of the body's natural wisdom to help it grow naturally, all the way to surgical treatments that depend on the doctor's wisdom and applying treatments directly to the patient. There are many things in here that we can do with MYOBRACE. We're going to go over some of those. But to try to figure out where on this continuum you're going to start with a patient is really an art in itself, and depends on a lot of the differences for each and every patient. And it's more than just the way their teeth are growing or even the shape of their palate. We have to discover what the underlying etiology is. So there are a number of things that we're going to do in the beginning to see what our child is about that we can't really see just based on clinical observation alone. We have to look at their willingness and ability to participate in a program where they're going to have to change their behaviors. We're going to have to look at their breathing and see if they can adopt new habits around breathing. We teach them how to keep their nose clean and clear. We look at their airway and their sleep as a way of judging just how much distress they're in. There's input from other professionals, including myofunctional therapists and body therapists, ENTs and physicians, pediatricians, and so forth, and also doing the myofunctional exam. So the discovery program using the K0 MYOBRACE has been very helpful for us. We base some of this on sleep testing. So there's a sleep ring called the sleep image that gives us an idea of how stable somebody's sleep is. Now, it's not always about sleep apnea. In fact, many people, while they're young, they still have the ability to respond successfully to challenges of breathing at night without going into apnea. But the work that's involved in handling the stress of breathing at night prevents them from getting a good night's sleep. And we focus on sleep only because the threats to our breathing are more significant while we're sleeping and our muscles are relaxed and our parts of our brain are turned off, that the compensations that we'll use during the day to breathe well, they don't work so well at night. So basically, we have the patients use this sleep monitor for about 30 days. Why 30 days? Because the company that is administering these rents them out for a 30-day period. And we take advantage of that. So we start off by having a child wear this K0 MYOBRACE. The K0 is important because if you're having trouble breathing through your nose, at least the K0 allows you to breathe through your mouth a little bit. We get them trained on it just to become familiar with it, and then we start our testing. At first, we use the ring alone, and get a baseline measurement. 3 or 4 days worth of testing will give us a good idea of just how much a child is struggling while they're breathing. Then we start applying the MYOBRACE, but also some other things that we'll talk about in trying to get a child to be able to breathe properly. And then we retest them at the end. Now, after that, I can do my final treatment planning because now I know just how much stress the child is in. So the MYOBRACE helps me see a lot of things that are really important in doing my diagnostics and treatment planning. One is, how compliant will a patient be with a MYOBRACE? What are their obstacles to compliance, and what can we do to help get them past them? You know, one of the things that people are always asking about MYOBRACE is, how do you get a child to use it? Well, it's a similar question to saying, well, how do you get a child to read a book? That's not something that they do naturally. It's often not something that they want to do, but it is something that's important to teach them. We have to help get them past it. We learn about how a child breathes through their nose. We do a simple 2-minute test just to see if they can make it that far. Many kids are so congested that they can't even do that. We get to see how committed the parent is to the program, because it does take time and effort. This is different than orthodontics, where we try to be in control as much as possible as orthodontists and eliminate cooperation from the patient's uh, uh, efforts. But in this case, if you're changing behavior, you cannot eliminate cooperation. You have to work with it. Well, maybe there are physical limitations that are preventing a child from cooperating, and how can we offer that help? What remedial treatment can we do for them? There are occlusal interferences, of course, in malocclusion, and there are ways of dealing with that. We have to make sure that there's enough room on the palate for the tongue. So doing palatal expansion can be very helpful, even though it's only one small part of airway treatment. We have to look at upper airway flow limitations and how much they're causing distress both day and night, and see what's getting in the way of their breathing. We look at tongue anatomy and whether there are tongue ties or lip ties that are getting in the way as well. So there's a lot to be discovered when you start using a MYOBRACE that most people think of as problems, and yet I think of them as opportunities. And I think that's important, because the obstacles that a child has are the ones that they need to have help with. So we look at things like the ability to breathe through the nose. I'm not going to go through this slide too much detail now, but we look at saliva management and the way they use their tongue and their primitive reflexes and tongue ties. We look at gag issues because they're very often either sensory or neurologically based, and usually a gag reflex means the nervous system is trying to protect the airway when it's under threat. We look at TMJ and occlusal and craniosacral issues, looking at the full body. We look at the sensory needs, the neurologic problems that children are having when they can't hold a device in their mouth. So that gives us a lot of information about what we need to work with. So for along this treatment continuum, there are a number of things that we can do with the MYOBRACE. For early on, we use it to help us train nasal breathing. In the biomimetic category, here we're trying to apply techniques that that take advantage of natural physiology. So we teach kids how to keep their nose clean and clear. We teach them the 4 goals of myofunctional health. We use it as a surrogate for the tongue, meaning that the tongue is really nature's palate expander. And when it's not being used properly, it needs some help. For growth guidance, it can be used for all sorts of things. And we'll talk about some of those today. But the underpinning of everything is really good myofunctional health, fascial balance, and of course, helping children develop an optimal physiologic airway and breathing pattern. So we use the MYOBRACE in breathing training, which can be really helpful. Now, there are a number of things that get in the way. They could be in the nasal valve, the narrowness in the nostrils, and so forth. We have to look at the internal nasal capsule and all the things that can get in the way that create narrow spots that inhibit flow. We look beyond the nose into the nasopharynx where the adenoids are, the soft palate, the uvula, and so forth, and where the maxilla has not grown forward the way that it should, so that these spaces become constricted. And of course, in the oropharynx, we're looking at tonsils, the displacement of the tongue when into the throat when the jaws have not grown forward properly. We have to look at a number of issues there. And of course, when the mandible is restricted, that's going to limit airway function as well. So it's very common for kids to have swollen tonsils and adenoids, and in their exam and history, we see that can be a limiting factor to breathing. And many orthodontists who have been aware of this issue will immediately send a patient to an ENT, where the ENT may give them medication or possibly surgery if it doesn't work. If the medication doesn't work, I'm going to suggest that by teaching a child how to breathe properly, that you can shrink the tissue enough to not only avoid surgery, but perhaps to avoid having to use medications on a long-term basis. So we have to deal with that structure, function, and behavior triad, which basically means help the anatomy by opening up the airway, reducing swelling and inflammation, and teaching good nasal breathing. So now if that works, then you've really saved the child quite a bit of distress. And if it doesn't work, well, yes, you may have to take out the tonsils and adenoids. But the problem with surgery is that a large percentage of the time, if you don't take care of why the lymph tissue was so swollen in the first place, that it can return. Some studies suggest 40% of children that have tonsillectomy will have breathing problems sometime in the future. So if that's the case, then you have to do breathing modification. And unfortunately, most ENTs do not have the wherewithal or the setup or the time or the staff training to teach breathing. And so my suggestion is, if you're going to have to do the breathing modification anyway, certainly start with it in the beginning. So here's a good example of that. This boy was 8 years old at the time. Now, it's not a terrible malocclusion. His teeth really seem to be coming in okay. I can see some collapse of the palate along the sides of the alveolar processes there. But when you look at his airway, there you see the constriction up by the adenoids and by the tonsils. He was able to breathe through his nose, and yet in this quality of life survey, there were so many issues that came up, including restlessness during his night's sleep and snoring, heavy breathing, some grinding of the teeth, and a number of the behavioral issues that are commonly seen with kids that are having trouble breathing at night, including attention deficit and learning problems and so forth. So when we use our screening technique for sleep, which is the sleep disturbance inventory for students, a validated questionnaire that we use, he was in the danger zone, really, of all the things that are measured by this survey. The first column being breathing during the night, the second column, restlessness, the third column, his sleep habits and circadian rhythm disorders, the fourth one, his daytime behaviors associated with breathing problems, and this fifth column is a summary column here. So we know that this boy is in distress. We look at his sleep. We look at his sleep image data, and he has desaturations, and his sleep is highly unstable. This is the picture of his tonsils, and you can see how swollen they are. Now, at 8 years old, sometimes it's not possible to get them to shrink if they have been swollen like this for years, and many times they are. If they become too fibrous, then they don't shrink so well. But fortunately for him, we were able to get through the protocol. We started with the MYOBRACE. We taught him how to rinse and clean his nose. We used a simple app to help him learn how to breathe through his nose, breathe a little more slowly, retain carbon dioxide, which will help reduce some of the swelling. We did use an ALF here to a light wire expander to help him the jaws grow properly. We used photobiomodulation to help shrink some of the tissues. He did have a tongue tie release, which was helpful for him. And by a little over a year, the tonsils, which are still big, they're just not quite as inflamed as they were, and they give him an opportunity to breathe better at night. So surgery was avoided for him. So what are the things that we taught him? One is we just do the 2-minute test. This is something that anybody can do in practice. And I encourage all of you to start doing this in your practice while a child is sitting there in the chair. Perhaps you're getting things prepared for their visit, if it's a hygiene visit or a restorative visit, or if you're an orthodontist, just laying out the arch wires or whatever you're going to do that day. Have them close their lips and keep them closed for 2 minutes. Watch what happens. If they can't keep their lips together for the 2 minutes, that's a strong indication that they're having airway flow limitation. So the MYOBRACE protocols give us the wherewithal for helping to deal with this. Of the 4 categories of skills that we're teaching with the MYOBRACE, the breathing is really, to my mind, one of the greatest things that we can do for a child. So they include making a child become aware of how they're breathing through their nose. That's the light breathing awareness. The PACE is about building up their resilience to carbon dioxide, which is often very low in the system and prevents the delivery of oxygen. And then how to keep their nose clean and clear. So built into the MYOBRACE protocols are a number of exercises and activities that teach them about slowing their breathing down, breathing through the nose, using the diaphragm to breathe. we teach them how important it is to breathe through the nose. This is a little exercise where they learn their diaphragm. And of course, by using the MYOBRACE alone, that kind of forces them to breathe through their nose. And the PACES exercise, basically, we use the MYOBRACE. They hold their breath while they're walking to see how long they can hold until they run out of air, and then they accommodate. Now the trick is to be able to go for longer and longer periods of time. Many kids in the beginning, they can only hold their breath for 10 or 15 seconds. But with some practice, we get them up between 40 and 60 seconds. And that has been shown to not only help them breathe through their nose better, but also help improve the delivery of oxygen to their whole system. So there are a number of apps that you can use to help train breathing. This one's called Address Stress. There are a number of them that I use. Well, on the right side of the screen, you see this ball. That ball expands and contracts as they inhale and exhale, and you can set the speed for that as they're breathing. We also have a list of exercises and techniques you can use to clean your nose. We actually teach them how to blow their nose, how to use saline spray or a saline rinse. We use essential oils of different kinds. There are all kinds of ways of helping decongestion. Some of those exercises that I just saw. Sometimes we'll use some of the over-the-counter medications, but we try not to use them for a long period of time. We really want to minimize the amount of medications, but we teach nasal breathing with the MYOBRACE or with all kinds of little other things like mouth tape or holding a little toothpick in between the lips just to encourage nasal breathing, and different ways of helping keep the airway open at night with nasal strips or nasal cones and so forth. We do dietary recommendations and also keeping the teeth clean. This is not necessary, but I happen to use capnometry as a way of biofeedback training. This is a really helpful tool because you can use this USB device plugged into your computer, and it will make a graph of how a child is breathing. And there's a lot that you can learn by looking at a dysfunctional breathing pattern and helping to train a optimal breathing pattern. So here's a typical case that I use for MYOBRACE, and not a difficult one. This is the kind of case that anybody can use. We're already in the transitional dentition here, but with a fairly common crowding of anterior teeth. In this case, it was class 1, and with craniofacial deficiency. We look at posture, we look at tethers, we look at the nasal aperture to make sure that it's open. We look at swallowing, all the kinds of functions of the face while we're doing this. But here we are starting the MYOBRACE treatment, and watching for palatal development. That is when the tongue is resting on the roof of the mouth, which is one of the things that we're training by the time we get to the permanent dentition. We have a nice wide open maxilla. We didn't really do anything in particular to the lower anterior teeth. We know that crowding is due to the musculature that bears on the teeth as it comes up. In this case, use of the mentalis muscle and lower lip to help close the mouth during swallowing is what puts the pressure on those teeth to misguide them into a crowded position. And when you start to change that, the teeth can find new positioning and a new equilibrium. Even if they don't come out 100% perfect and you want to do some dental alignment, the dental alignment is always so much easier after you use the MYOBRACE for that. But here was the breathing pattern at the beginning, and really not terribly dysfunctional, but a little bit quicker than really needs to be done, and her CO2 levels were a little bit low. She took to the training well. You can see that as those tracings start to spread out, she's learning to slow her breathing down, and eventually we build up her CO2 levels. Now, that doesn't mean that somebody's going to breathe this way all the time, but there are times of stress when breathing tends to get worse than others, that using these breathing techniques can be very helpful. And when you can breathe well this way, the chances are you'll be breathing through your nose when you do. Of course, the MYOBRACE is most useful for myofunctional repatterning, and that is we're teaching the 4 goals of myofunctional therapy. That is breathing through the nose, having the tongue rest up on the palate, being able to swallow using your tongue muscles and not necessarily using your lips, chin, cheeks, or neck to help you swallow. And of course, having the lips together at rest, which of course is necessary for good nasal breathing. So we also teach, we use the MYOBRACE for teaching those 4 things. The MYOBRACE is kind of a simple rubber device, much like a sports guard, but it has certain features to it that make teaching these 4 goals easy. And that is, it's got the lip shield in the front that blocks oral breathing and helps to establish nasal breathing. It has the flange on the front that have these little nibs that are supposed to discourage mentalis contraction. And the mentalis muscle is a hard habit to break, but at least this can be helpful. It has a little tongue spot for placing the tongue up on the palate, and the channels to guide tooth eruption. And then finally, the inside shield, which keeps the tongue from contacting the teeth during swallowing. Now, we ask the kids to wear this for 1 hour a day, where they're going to be doing conscious training of their tongue posture and swallowing. And there are a number of exercises and activities that go along with that. We also have them wear it to bed at night while they sleep. This is to allow the muscles to practice what they've learned during the day and help solidify some of the new neurologic patterns that are going to be created in the new swallow. So there are lots of different models of the MYOBRACE. There's the one for the kids, there's one for juniors, there's one for infants, there's some for teens, and so forth. You can go through this with Shlomit and Moshe about what series that you're going to pick. Perhaps when I come in November, we'll go into a little more detail about which ones to choose. But suffice it to say, it's good to have a little bit of an inventory of these things so that you have the ones that you need. You don't have to stock up really a large inventory. Just have a couple of the ones that you're going to use pretty frequently, in place. This is my storage area in the office, and I have the ones that I tend to use, available for me. But it's really not about the MYOBRACE itself. So I know people get all confused about which one they should use and all that. But I encourage you to think about it this way. It's not so much about the MYOBRACE trainer itself. It's about what you're training with it and how you train. So I frequently say it's sort of like going to buy dumbbells or use dumbbells at the gym. Doesn't matter whether you pick up the He-Man metal ones or the pink ones or the round ones or the hexagonal ones. It's not the dumbbell that makes you strong. It's the lifting of the dumbbell that makes you strong. And it's not having the MYOBRACE, it's using the MYOBRACE properly. So there are all these different activities that we teach about breathing, about tongue posture, about swallowing, and about lip and cheek posture and use. And this is really what is so essential. So MYOBRACE, and I think the reason I use it above all the other available myofunctional trainers is that the protocols that they've set up are so helpful. And they include all of those categories in what is now going to be an online app, so anybody can access it. They have videos that teach the patient about why it's important to use. I'm not going to play that all, but then there are all the different activities, and each of the categories has several activities to it, and there's a video that goes along with it. And when they're done, they take a quiz, and the quiz
resting position.
And the quiz, helps them solidify this concept about each of the activities. Now, it's also important to have a place to teach this in your office. This was my MYOBRACE center, but I had to grow into this. When I first started, I did not have such an elaborate studio for it. But it's important to have something, because trying to teach the stuff to a kid in a dental chair is really not very helpful. I was told that you can't play basketball on a football field, and you can't play football on a basketball field, and you should do dentistry in a dental chair, but you need a teaching studio to teach good activities so that the child is not worried about what's going to happen next. So this was my first station. It was just a monitor on the wall. Now you can use an iPad. You have a mirror there so a child can see themselves in the mirror. One chair for the patient, one chair for your dental assistant or trainer, a squirt bottle and a stopwatch for certain of the activities. And that's all you really need. And to tell you the truth, after the pandemic, I had lost my teaching studio because I had to change in ownership, and well, it's a big story, but I'm back to this one monitor and mirror for the moment. And I'll show you what else I'm doing. But once I got one station going, then I needed two. So I set up a spot in my reception room. Or you may have an extra operatory that you're not using, or a consultation room that is usually quiet during the day. I worked up to 3 stations when I developed a room specifically for training MYOBRACE. That's me and one of my patients. And then finally to this, branded room that we had, and it was great to have. And there's lots of benefits to having it this way. But it's really not so much about the room as much as it is about the MYOBRACE coach. And so this is what I want you to understand, that there are certain things that you want to have in a good coach. First of all, you want someone that's on your staff that loves to work with kids, that has a positive outlook about things. Having them also have an idea of wellness and health about themselves is really important. But they don't necessarily need to be trained highly in myofunctional therapy, because the protocols and the videos really help them teach. Now, you can get a certification for MYOBRACE, and as we're going to see, if you're a myofunctional therapist, that's even better. But if you have a hygienist, or if you have myofunctional training, and you can do an oral assessment and you have enough knowledge to be able to troubleshoot, that's even better. But I'm going to say the best, and this is not so common, but if we can have a physical therapist or an
אלכס,
OT that does manual therapies along with that, like craniofacial or fascial release, craniosacral therapy or fascial release techniques, or breathing repatterning, that's what I see as the future of orthodontics and pediatric dentistry. So there are certain things that your coach is going to do in your office. And this is what I'm going to suggest to you. This is using the MYOBRACE is not the dentist's job. Yes, the dentist has to know what we're trying to achieve and be able to evaluate the success of the program. But you're not going to be running the program. The running of the program is going to be done by your MYOBRACE coach. What are they going to do? They're going to help organize the program for you. They're going to learn the apps and learn it word for word so that they can help teach it. They're going to do the new patient intake. They're going to introduce the MYOBRACE to the parent and to the family. They're going to assist the doctor at the exam. They're going to arrange for records and consultation. They're going to deliver the MYOBRACE and give instructions. They're going to teach the activities. They're going to help collect progress records and debrief the doctor on how the patient is doing. They're going to administer a rewards program, or other kinds of things that help motivate the kids. They're going to help administer the progress reviews. We do one at 3 months and at 1 year. And we give awards and we do celebrations, and we promote this to both within our practice and outside to get people involved. This would be a great time to take a screen grab of this slide for doctors. You're going to hand it to the person that is going to run the program for you, program directors. This is a general outline of what you need to do. So in our office, we have a MYOBRACE coordinator who is a myofunctional therapist, and she's responsible for teaching the coaches how to do the work. When the pandemic hit and people were not coming into the office, we immediately transitioned to teaching online. And that was so successful that 80% of our MYOBRACE training is now done online. This is a copy of my schedule for this particular day. And those are my orthodontic patients on the left-hand side of the screen. But on the right-hand side of the screen, with the pink outline, these are my MYOBRACE training appointments. And these are all outside the office. These are all being done online. Even when I'm not seeing patients, we can be doing MYOBRACE. So this has made things more convenient for parents, because they don't have to travel to the clinic in order to have the MYOBRACE training done. And it has relieved some of the burden on the facility by not having to take up chair time or having on-site staff participating in the MYOBRACE training. So we've really made it very versatile. It's true that some patients need the kind of attention that they can only get when they come into the office a certain ones of those trainings are done that way too. Just a brief word about some of the adjunctive therapies that I use MYOBRACE for or with. You know, I know there are a lot of places throughout the world where they use MYOBRACE in, you know, as a standalone treatment. As an orthodontist, I tend to pair it up with other kinds of therapies too. Simple cases, yes, I handle with MYOBRACE alone, but many of the cases, especially the ones for biomimetics, I use things like the advanced light wire functional, which is an offshoot of the old Crozat system. It is a way of being a surrogate tongue, not a palate expander as most people will think of it, but as a way of changing the direction of maxillary growth and mandibular growth. There's also a light wire expander that's done with MYOBRACE called the bent wire system. This was developed by Chris Farrell, not unlike the ALF treatments, but used mostly as a way of boosting the effectiveness of the MYOBRACE. I do a lot of coordination with myofunctional therapists who are usually either speech and language pathologists or dental hygienists who do private coaching and counseling with patients, but they find that using the MYOBRACE maybe a little bit during the day or certainly at night while the child is sleeping helps reinforce some of the things that they are teaching the children privately. I use a technique called planus tracks, which are composite toppers that are bonded to the top of the primary teeth to help guide the movement and development of the jaw. These are good for cross bites, for mandibular retrusion, or maxillary sagittal development, but they don't really train good muscle function. And so you can use the MYOBRACE right over the top, which is really, really helpful for that. I do use expansion, either the removable type or the fixed type in practice. And while I don't do the MYOBRACE while I'm doing the expansion, I do use it after I'm done with the expansion to help maintain the gains that we've made with the expanders. I know that before I had the MYOBRACE, I would have to expand an extra 20 or 30% because I knew I was going to lose a lot of the expansion that I had gained. But when you move to MYOBRACE, you're now training the tongue to be the expansion retainer. And so we don't lose as much, and I don't have to overdo expansion as well. So when I finish with the expander, I'll usually make an overlay retainer just for an immediate placeholder so that teeth don't collapse. But then I start the MYOBRACE right away and then start the training going. As soon as I know they're good with the MYOBRACE, then I reduce the retainer because retainers will only limit growth. They'll not only hold growth, but they'll limit further growth. And then I use this for BioBlock training too. The BioBlock is a way of helping the mandible catch up with the developed maxilla. And when I start weaning the kids off the BioBlock, I'm also getting into myofunctional training with it. So here's an example of what I'll use MYOBRACE for with the ALF appliance. This is a very, very typical case. You look at the primary dentition and the teeth all look straight because they're all standing next to each other, not realizing that primary teeth are supposed to be widely gapped. And then you don't really see it until they start to fall out and you see the permanent teeth come in and there's not enough room for them. And most people will say, oh, yeah, well, you'll need braces, save up your money for when the baby teeth fall out. But by then, most growth has already been, whatever growth was going to happen has already happened. And that's when you're in a situation where you have such crowding that you consider taking out permanent teeth to solve the problem. And it's just not necessary. Instead, help the jaws grow from an early age so that by the time the permanent teeth come in, there is enough room. So this was such a case where we used the light wire expander on top. This is the ALF. And again, it's not so much an expander as it is trying to be a surrogate tongue to develop the growth of the maxilla, and with the MYOBRACE, the growth of the jaws. I didn't really do anything else to the lower jaw. So this is July. This is September, 1 year later. And now you can see there's spaces there so that by the time the permanent teeth come in, there is enough room for them. The yellow lines there show the scaling of the development of the arch. And this is a comparison of a photocopy of the ALF before we started and the photocopy of the the actual ALF laid on top of the photocopy to show both the transverse and sagittal width that we got. Now, this kind of a technique is very slow. This is not about trying to force the sutures apart. This is about helping the jaw grow better. The metaphor that I use is that Aesop's fable about the tortoise who wins the race against the much more rapid hare because the hare just falls down on the job, which is what happens when you take palate expanders out. Here, we're actually getting natural growth. Here's a before and after of using palate expansion. There are people that have shown using just MYOBRACE to solve these kinds of cases, but I tend to use expanders. This one was with BioBlock. You'll see similar things with the fixed expanders. But look at the shape of the palate and how the palate's descended and how it's broadened out. You have to be able to maintain this. This doesn't just stay by itself. Teaching the tongue to get up to the top of the palate really is important. So I also use the MYOBRACE for some other things. There's retention and eruption guidance. There's you can do some myofunctional therapy during orthodontic treatment with the braces series, and we do some TMJ and occlusal therapy as well. So that's about all the time that I have. We'll take some questions, Shlomit. But just to let everybody know, we've got a third seminar coming up on June 22nd. I'll be talking about records collections and setting up a portfolio, and then using the discovery program maybe a little bit more. In some specific cases, we'll do some case studies and outcome measures. And then hopefully I'll get to see everybody in Yerushalayim in November.
So anyone has a question that you would like to ask? So this is the time. Yes?
I would be interested if people are a little too timid to ask questions, to put up in the chat what your what part of the profession you're in, what is it that you're doing, and are you using MYOBRACE, or perhaps type some things in that may be problems for you. Let's do it that way, and then I can
Awesome.
answer some questions. I see my friend and mentee Hadass here tonight. Hello, my dear. How are you?
You can speak.
Hadass invited me to Tel Aviv in November, where we had our face forward event. I have my
Yeah.
my coffee cup here, and she and I have been working online for some of our techniques. She's coming to the United States this summer. She's going to learn a little bit more, and then she's having me back in November.
Yeah.
And I hope Shlamit and Moshe take advantage of me while I come as well.
So anyone has a question, something you like to
Yeah, tell
consult
me.
with Barry or ask, or don't be shy. We are
Don't
all
be
friends
shy.
here.
At least tell me what are you doing? Are you in dentistry? Are you in
You have
therapy?
here
Are you body?
dentistry, you have here pediatrics, you have one that she's potato breathing. She's
Oh,
here. You have another pediatric. You have a speech therapist here. You have facial and oral doctor. You have here many, but I think they are all a little bit shy here.
all right. Or am I not seeing their messages?
Yes.
I don't see anything coming up on chat. Um,
But they are
any,
here, they are listening, they are
all
you are
right.
educating them. It's very important.
All right, good. You know what I like to hear, because I went through this myself. I was an orthodontist for 30 years before I started thinking about myofunctional um, anything, frankly. And there, I don't know how you say bullshit in Hebrew, but oh, is it? But when you come upon something new that doesn't really match with your current orthodoxies, your current way of thinking, you tend to look at things with a critical eye and say, "Oh, that must be bullshit." And I went through that, and I know what it takes to change your protocol, what it takes to change your way of thinking from just, well, anatomy and angle classification to looking at the fact that malocclusion is not really the problem. Malocclusion is a symptom of something else that's going on in the body. And it's a rather large paradigm shift. I don't know about what's going on in Israel for medicine, but we're starting to have this shift in medicine here, realizing that all the things that classical medicine does to treat symptoms is just not good enough. That we have to be looking at the root causes of all these chronic diseases that are bothering us and our children. And unless you start changing your way of thinking, it's very hard to look for real etiology. Our systems are set up for dealing with symptoms, and really orthodontics is exactly that. And changing our way of thinking to looking for power. So if anybody wants to say just how much this could not be true, compared to what you were taught in program, that's what I want to hear. That's what I want to talk about. So nobody's even saying hello to me.
Hello, I will say. But I do believe that everyone here is, a little bit shy.
Yeah.
I don't know. But they're asking a lot of questions, and if they will have questions to you, I will send you an email, and
All right,
if
sure, we could do that.
okay,
Yeah,
will
I'll
want
put,
to ask something,
yeah,
so I'll send you an email. And our next webinar will be on the 20, I don't remember.
22nd, yeah.
22nd. Okay, great.
Here, I put my
And
email address.
November.
I put my email address in the chat.
Okay. You have the email address of Barry. You can ask him questions if you have. He will be glad to help you.
I'll put up my website too, because
Okay.
I have a lot of information about my protocols on there.
Okay.
You can click on that, take a look at it.
Just a second. I will copy it, so I'll have it. Yes.
Barry, thank you. You hear me? Thank you
Yeah.
so much for being so generous with your knowledge and keeping up, being in touch with us. They always say that Israel is 10 years behind the States, but you make us get there even sooner.
Yes,
So,
absolutely.
Thanks for
Small
that.
steps.
Yeah.
So thank you everybody for joining us. It was great seeing you here, and I hope we can work this out and start, working with MYOBRACE. And I'm delighted that you are here. If you need anything from me, אם מישהו צריך משהו ממני, חומרים, לראות קורסים אונליין, חוברות עם תרגילים, אז I will be happy to assist. ואני אשמח לעזור, ו-thank you very much. Thank you, Barry.
You're welcome.
ביי, ביי ביי.